Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. All right, Dr. LaCasce, thank you so much, my friend, for coming on Healthcare Unfiltered Express. I recognize how busy you are, but I really appreciate you making the time. Thank you so much.
Oh, it's a pleasure to be here.
So we're going to chat a bit about advanced stage Hodgkin lymphoma, once called Hodgkin's disease when you and I started training. But a lot of things that happened, and we're going to try to just simplify it to folks who are listening and watching. So when they are faced with a patient with advanced stage Hodgkin lymphoma, it's very easy to make a decision on what to do. So what goes through your mind when a patient with Hodgkin lymphoma comes through the door with advanced stage?
So I think you want to look at the patient in terms of any underlying medical comorbidities and age and performance status. But with some of our new therapies, that's a little bit less of an issue because we're using predominantly Nivolumab plus AVD, which you can give to older patients. And we know the outcomes of those patients in the S1826 study was really quite amazing compared to brentuximab plus AVD in that randomized study, with the caveat that it was a small number of patients because we knew BV-AVD is not a well-tolerated option when given all together for patients, older patients. But that's been a real nice change to be able to have a regimen that we know has a high rate of long-term disease control that we can use in patients over 60.
So when you have a patient, let's go with a younger patient first, and
Yes.
60 seems to be the cutoff right now. Is
Yeah.
that? Yeah, for Hodgkin specifically. So for younger patient, advanced stage, do you do Nivolumab, AVD for everyone? Are there patients where you do not do this regimen for?
I am using Nivolumab AVD for almost anyone. Obviously, patients who have active autoimmune disease, where there's a contraindication to a PD-1 inhibitor, there I would not use Nivolumab. Obviously, the elephant in the room in advanced stage Hodgkin lymphoma is the BRICAD regimen from the German Hodgkin study group, where they compared BRICAD to escalated BIACOP, and BRICAD had really outstanding outcomes with less toxicity than escalated BIACOP. However, more than a third of patients in that study required 6 cycles of therapy, and it is a very toxic combination. A third of patients, or 30%, had febrile neutropenia, needing hospitalization. They need blood and platelet transfusions. So I have not used BRICAD at this point. The outcomes are really amazing. But I think if I had someone who had very high-risk disease where I thought Nivolumab wasn't a good option, then I would certainly think about BRICAD. But, patients need to be followed very closely for toxicity on that regimen.
And patients over 60, Nivolumab, AVD for everyone?
Yeah, I think we can give anthracyclines to patients who are quite elderly. I mean, I think we have a lot of experience in diffuse large B-cell lymphoma. We can follow ejection fractions. If patients have borderline EF, you can add dexrazoxane. We give statins to all these patients based on the STOP-CA trial from MGH and Dana Farber, where by giving 40 of atorvastatin for a year, there was a reduction in the risk of dropping ejection fraction. So we really are able to give it to quite, patients clearly in their 70s and even maybe early 80s. Once you get to patients who are really frail, then we're thinking, well, maybe we would try brentuximab plus Nivolumab as one option. We know that a lot of those patients will ultimately relapse, but it can be relatively well tolerated, and that, for that really, really elderly group of patients.
You mentioned the SWOG study, which looked at the elderly, but it was a subset analysis, right? I mean, do you have any concerns that it was subset analysis or?
Well, I think not only that, but there were only about 50 patients in each arm because of, referral bias. when we had the study open, I would not have referred a patient, an older patient for this study, 65 or older, because I wouldn't want them to end up getting BV-ABD altogether. So I agree, though Alison Moskowitz and the folks at MSK also did a study of nivolumab plus ABD in older patients, and the outcomes looked quite similar. So I do think that it's a good regimen. And, a lot of these older patients with Hodgkin lymphoma have mixed cellularity or EBV associated disease. And we saw some subset analysis from S1826 at Lugano. Sarah Ahmed from MD Anderson presented this data where Nivo-ABD, it really has, with BV-ABD versus Nivo-ABD with mixed cellularity or EBV-associated disease, there's really a big difference in outcome. So, that was really interesting data to see. I think what ultimately, the Germans have looked at ctDNA, gene expression profile, and really trying to identify subsets, genetically defined subsets of Hodgkin lymphoma. And there may be a subset that are not driven by 9p24 and PDL1, ones that are more sort of oncogene driven, and those patients may do better with standard chemotherapy. So more to come on that. And I think the other thing that we saw at Lugano that was really interesting was looking at changes in ctDNA during the course of therapy. And hopefully that's going to allow us to reduce the number of cycles in patients who clear their ctDNA early. So that work is pretty early, but it did look quite intriguing. And there are a number of ongoing studies that are being designed asking the question, can you use ctDNA to tailor your therapy and reduce the amount of chemotherapy that patients are getting, which is pretty cool.
And do you do anything to kind of minimize the possibility of autoimmune side effects with the checkpoint inhibitors? I know they could happen, and we usually
Yeah.
treat them when they happen, but is there anything you can do preemptively to also, is there a phenotype of a patient that you think might be higher risk of developing some of these toxicities?
That's a great question. I don't know of anything preemptive that we can do. Obviously we get baseline thyroid function tests, and hypothyroidism is very, probably 15-20% of patients, 10-20% of patients. It's really quite common. These other toxicities that are more severe or unexpected, I don't think we know at this point. I think there is some emerging data, maybe in melanoma from MGH, where I think they had identified there are some characteristics of the host that eventually I think we'll be able to understand better who may be at high risk for developing those toxicities. Because you're right, I mean, they can be really, fortunately, myocarditis is unbelievably uncommon, but, for that to happen in a 20-year-old with a curable disease feels, terrible.
Do you usually stop therapy with Nivo when you see autoimmune or myocarditis? Can you resume? Like, is there particular guidelines for this? What you deal with that?
Yeah, I mean, I think it depends on the toxicity. I think you can often retreat patients after, treating them with steroids and tapering them down on the steroids. I think myocarditis is one that probably would not be something that I would retreat or really severe grade 4 toxicity. But, we do see, rash, very common in these patients. And you can definitely retreat patients with rash. But some of these other toxicities, I think we can learn a lot from our solid tumor colleagues because they've been using these drugs for a long time. So it's nice to have them as a resource to say, we don't see them as often. We're not using these drugs as often. How do they manage them?
Yeah. Well, it seems like the advanced stage disease, nivolumab ABD, is pretty much the consensus right now, if you can and you monitor for side effects. I guess my last question before I let you go is, are you seeing this regimen moving to early stage disease? I know this is a completely separate topic that we'll address at
Yes.
a later date, but maybe give us a teaser. Is this possibly happening for early stage disease?
Yes, it's definitely happening, particularly for high risk early stage disease, patients with 2B disease, or even patients with extensive stage 2 bulky. The NCCN guidelines have included Nivo-ABD. If you look around the world, there are many other Canada and Europe consider these patients to be high risk, and those patients were included in the HD21, the German study. So I think people have extrapolated, well, if it's that much better than BV-AVD, which is better than ABVD, they sort of extrapolate. It'd be nice, we have this big US intergroup study led by COG ongoing right now, starting with ABVD and using PET scan to risk adapt people, and patients are getting BV-Nivo based therapy as the experimental arm. So I think it's a very large study. We're going to learn a lot from this study because there are some patients who are going to do extremely well with early stage disease with 4 cycles of ABVD or a RAFL type approach. Which is obviously cost effective and very well tolerated. We know exactly what to expect. But for those high-risk stage 2 patients, we are seeing that a lot of people are using Nivo-AVD, and I'm sort of 2 minds about it. I'd like to see more data, but I think I'm seeing it more and more, and I certainly understand the argument. And these are young patients; you really want to cure them, so. I think it does make sense in some situations to use it in early stage disease.
Dr. Ann LaCasce, thank you so much for coming on Healthcare Unfiltered Express.
Thank you for having me. It's a pleasure seeing you.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.